So we can open this session, yes, for 5-minute discussion. We can start with the first presenter, Dr. Said Al-Bisi. I'd like to ask him about the concerning the inner branch technology. Is there a critical diameter so that beyond it you should go for the inner branch technology? I mean, which is the diameter that you'll say, I will go for the inner branch technology, I will go for fenestrated branch? And the second question, please, what about the cases with chronic type B dissection, and they have already a very narrow lumen? Is it will be a solution for that problem?
Very good, thank you. Yes, for the first question about the lumen, we determine the design according to the lumen. So that I think the ideal lumen for inner branch between 20 millimeter to 26, 28. If there's more than 28, the outer branch or T branch would work as well. So it doesn't have to be inner branch. You can also use inner branch if you want to, but the ideal diameter 20 to 28. Less than 20, it gets a little bit too narrow in a normal aneurysm, and maybe fenestrated is a solution. Now, for chronic dissection, the aortic lumen for the second question is very narrow, and the very narrow aortic lumen in chronic dissection is a different character. So inner branch would work on it very well because it's soft, it pushes away as compared to the normal aneurysm where it doesn't push away. Having said that, the experience in chronic dissection is generally limited, so it's difficult to give 100% definite it works all the time. So the numbers are small for chronic dissection, but so far seems to work, and it does also work with other designs. So it's not the only design. So I think chronic dissection, we need a bit more time to give you a definite answer. So, yeah.
If I may, congratulations, nice presentation. I'm also using the inner branch stent grafts, and apart from the advantages you just mentioned, and I think there is one which at least we experience. I'm going to present that tomorrow morning, but I just want to ask you, because the size of 24 French is really huge, and if you have to, for the preloaded inner branches, if you maintain that stuff within the 15 minutes, because it usually takes the time, you know, when you cannulate all the vessels, it is a huge impairment for the hypogastric perfusion. And what we do now, if you are experienced, you do not need any preloading. So we are just placing the stent graft inside, we remove everything, and we cannulate the vessel, the branches, without any preloaded guide wires. And it helps us, you know, to avoid the long standing time of lack of perfusion. I don't know, what is your experience?
I think it's the same, and I remove them and maybe do retrograde from below. But we have to think about the bigger picture, in my view. I have also been to center where they did the very first case. And for very first case, pre-cannulation is very useful. Obviously, you have an early experience center, they will have a very large iliac artery to start with. They're not going to go to small artery, so perfusion is not big. So things are relative. I think the point we have here, when we have one design, we don't apply it for all conditions, or we don't use it all the same way. I think as per patient, as per your individual experience. But I agree with you. I think this is one limitation, but also advantage sometimes.
Of course, yeah, as always.
Can I ask a last question here? Yeah. One of the problems with a branch is stent graft dislodging. Do you think the inner branch has more stabilize for the branches? I mean, do you have any comparison to say this is better than branched to give it more stabilization?
So, direct comparison? No, there isn't. Specific data where we looked at our bridging stent in the last 5 years in inner branch and in outer branch in about 160 cases, and we published it, and we didn't see dislodgement. But I don't think this is necessarily a branch stent graft design. I think the bridging stent are much better. In the past, the dislodgement we've seen mainly in self-expanding, poor quality stent. We moved to a better radial force, more stable stent. So, and we haven't seen dislodgement. Now, I think conceptually, it sounds like the inner branch is more stable. You have less gaps, less sac, things are stabilized. So I expect less dislodgement, but there is no comparative data. And I think time has moved on. People are using more advanced bridging stent. No one's prepared to go and use older one and try to compare. So it's really difficult to get these data. By personal experience, we see them quite stable.
Thank you very much. Professor Amrgad, since mic is yours.
The question is Dr. Marat Salam, please. Thank you for this nice presentation about the graft infection. I would like to know, for the people to know as well, what are the early signs when you suggest the presence of graft infection? Is the presence of air around the graft during CT scan examination? And second, in this era of endovascular techniques, EVAR and TEVAR, do you find that these grafts are more liable or more prone to infection when you found in your series, or the standard aortobifimbrous bias? Thank you.
So the first question is, we use the MAGIC criteria, which is a combination of major and minor criteria, radiological, biochemical, and clinical. Each one has 2 or 3 major and 2 or 3 minor, and a combination of a score will make it a graft infection. It's a very valid, very useful tool. Air is a major criteria if it's after 3 months from any implantation or intervention, and one major with any minor, and you will probably have a minor with air around the graft, will be diagnostic. But we use criteria, and we've been using it. We validated retrospective. I think it's a very useful tool. If you use the MAGIC criteria, we have got now a sensitivity, well, a specificity of 100%. We never taken a graft out that turned out not to be infected. I hope we haven't missed any. That's one. The second question, which is related to, sorry, the second question was?
In your experience, I know that experience in
yes, so the endograft.
Yes.
Yeah. So what we have seen actually in our experience is endografts and open grafts are 50-50 from the ones that ended up infected and explanted. This is around 120 total. We've explanted more than 70, and we have seen fistulas with endografts, which is very weird. Fistulas to the sac, fistulas to the neck. So it's not only with open that you get a duodenal fistula. You can get a fistula with endografts, particularly sac expansion and multiple reintervention. So we found in the endovascular group, the ones that got fistulas and the ones that got graft infection had risk factors of reinterventions or sac expansion, rapid sac expansion, because one of the endo leaks and it causes inflammatory process and then infection can come. So I wouldn't say that open or endo are a little bit more. Occlusive disease seems to be more difficult to cover the grafts, and they can poke in the duodenum with time, but not enough evidence on that.
Thank you.
Dr. Murat, I have a question for you.
Yes.
Thank you for your interesting presentation about mycotic aneurysm. Is mycotic aneurysm always infected? So what is the proof that it's infected? It is just, we describe this from the shape of mycotic aneurysm. This is my first question. And also penetrated aortic ulcer can end also in saccular aneurysm. So this is my question for you.
Yeah, not all saccular aneurysms are infected or are mycotic. So mycotic by definition is actually not a very accurate terminology, but it is an infected aneurysm. But you are right, the morphological saccular is one factor only of the diagnosis. You need to marry that with either bacteremia, high white cell count, high PET scan uptake around it. And I agree with you, some of them can be quite confusing with a penetrating ulcer, borderline inflammatory markers. So their diagnosis can be tricky. There is no equivalent to the aortic graft infection scoring system. But I think you have to prove that it is infected to start doing all of the hassle. And if you are in doubt, then maybe it's a penetrating ulcer.
Because the swab, what I take intraoperative, and the results come after this.
Yeah,
so
yeah, you can, but some of them are culture negative, some of them
I have to do a plan pre-operative. This is my question.
Yeah, well, that's the problem.
Whether it is infected or not.
You can take blood cultures, you can take peri-aortic sample, but that is why if you put an endo first, you get a bit of stabilization, you can go and puncture the sac after you have sealed it, and get more idea. If it is infected, it will declare itself, and you manage it differently.
Thank you very much.
If I may, sorry.
Yes, please, go ahead, please, go ahead.
Just a short question. Congratulations. I like very much your algorithm for the management of infected stent grafts or the grafts. I just want to ask you, how often do you do the PET examination? Because in our experience, we just refuse to do it because it's very expensive and it does not any additional value when we want to treat the patients. We rely much more on the MRI, which is a cheaper one. So that's how often do you use that?
We probably overuse it. We use it a lot. Yeah. We've learned to kind of use it as a prognostic factor. We use it for planning. We use it for diagnosis. But this is because we have an amazing unit of nuclear medicine. And I agree with you, some other imaging could replace that if you do it well. But MRI is not cheap, is not easy, and not as specific when it comes to the planning like the PET. But I take it completely. It is expensive. We use plenty. And there will be literature coming in the coming couple of years of PET scan being very specific and sensitive and helpful on the different stages.
Okay, we'll see. Thank you.
The last question, please, Dr. Hussein, for the sake of time. You can please.
Just one question. Thank you, Murad, for a wonderful presentation. What do you do? What do you do for ruptured mycotic? So you will temporize it by an endograft, but are you just going to treat that with antibiotic and see how they do, or you take the endograft out and replace it?
So previously we used to be very aggressive by putting the stent graft to get them out of trouble if there is no technical compromise. So if it's not visceral segment that would require chimneys and snorkels or arch, we would put a stent graft and go ahead and take it out. But with time, we have learned that some of them might get away without explanting. But it's very difficult to select them. So what we do now is we put a stent, we start them on antibiotics, and if they respond well, inflammatory marker goes down, we give them a year and stop. If they relapse after a year, they are a graft infection, they go to a different pathway. If we stent them and they never respond to antibiotic, they stay with a CRP in the 50s, a little bit unwell, some pain, some extension above and below the stent and peri-stent collection, we again call them poor responders, stented mycotic, they go to graft infection, we take them out.
So Dr. Salam,
maybe another question. Yes, you can proceed. Yes.
I apologize. Dr. Piferetti from Italy. I really appreciated the SGT protocol for aortic graft infection. We are deeply involved in such demanding scenarios. I would like to know if you have elaborated or integrated a GI algorithm of flow to make a standardization of the GI side of the story of the secondary aortic graft infection, because you know, sometimes we are successful in explanting the graft and we lose the patient from the GI side. Thank you so much.
I can't agree more. One third of our patients that we the fistula. 1/3. Usually a bowel fistula, duodenal, esophageal, sometimes colonic. So I agree with you. Yes, we do for the ones who are bleeding, upper GI endoscopy to stop any bleeding that is stoppable. Half of them say we couldn't see anything and there is a fistula. So don't rely on it because fistula is usually D4 or DJ. And the second thing is GI surgeons come and do the reconstruction. I learned to do it, I can do it, but we don't do that anymore. They come, I take a break, or the team take a break, they fix it. We have a strict nutritional support to those patients after that. And actually we have very low leak from the duodenal fistulas that are repaired. They're still worse in terms of their microbiology, much worse, polymicrobials and gram-negative, and they die probably double the figures of the non-fistula group.
Yes, but generally speaking, general surgeon, they prefer to go directly with a suture, or they
Primary.
Are more aggressive with duodenectomy,
so,
etc.?
Any belly, any duodenum downwards, from D3 downward, primary repair, very aggressive primary repair, and double omental patch. One on the duodenum, one on the aorta. Esophageal, we are split. We don't have enough. Some resect and do a gastric pull-up substernal, and some do primary repair. We've done only 5 of those. We can talk about them, but they're not big enough for me to say. I highly recommend an upper GI, a good general surgeon, to do the duodenal repair primary and put an omental wrap, and it does work. We have now at least 25 primary repairs that work really well, and one only leaked.
Thank you so much.
Dr.
Okay,
Nasser,
thank
thank
you
you.
very
We have
much.
to end this session. Thank you very much.
I think you are
Thank you.
enjoying your staying here. You will not never leave. Please, we come to finishing this session. Thank you, Mr.
Thank you very much.
Chairman. We're coming for the very exciting session. It will be running by Dr. Rashad Bishara. I'm dead sure it will be very exciting and very helpful for us. So, Dr. Bishara, you can start your session.
Thank you, Professor Nasser Said.